So hello everyone and welcome to this extremely important session on temporal bone imaging, where I'll be taking you through some of the interesting cases of the middle and the inner ear. Although it's very important to understand the anatomy of the temporal bone first to actually diagnose any pathology. So I'll not be covering the entire anatomy in this particular session because that is for you to sit in the console room and do it for yourself. But I'll be covering the relevant anatomy along with the pathology during the imaging. So starting with the first case, so here we have a patient with bilateral conductive hearing loss and otorrhea who got a HRCT of the temporal bone done. So what do you think the diagnosis is? So this is the coronal section where I'm scrolling from anterior to posterior direction, where we can see soft tissue density within bilateral middle ear. You can see the tegment tympani and the scutum also. The ossicles are also very well seen. There is some surgery that has been done here, probably a canal wall down mastoidectomy. Again, the soft tissue density, you can see the tegment tympani and scutum and the ossicles within the middle ear. Coming to the axial sections, again we can see that soft tissue density in bilateral middle ear. You can see that ice cream cone of the head of the malleus and the body and the short process of incus. The soft tissue density filling the middle ear cavity. So what do you think the diagnosis is here? Do you think the tegment tympani was eroded? The scutum was eroded or blunted in any way in this particular case? So there was no erosion as such if you go through the imaging again of the tegment tympani or the scutum or the ossicles. So it's a case of chronic otitis media, but there is no cholesteatoma that is associated with this particular condition. So often it is given in the reports that it is overdiagnosed, the tegment tympani erosion, and the patient is said to have cholesteatoma along with the CSOM. But there is usually thinning of the tegment tympani in chronic otitis media because of the inflammation. There is some rarefaction and thinning of the tegment tympani, but it should not be overdiagnosed as to having eroded. So now coming to the next case where this patient presented with left-sided hearing loss and ear discharge, and we'll be seeing the HRCT picture first of this particular patient, left ear, where we can see that the ossicular chain is disrupted. There is reduced mastoid hair cells and some destruction of the cells, giving rise to coalescent mastoiditis, and the ossicles are completely disrupted. And there is soft tissue density within the middle ear cavity. On MR imaging, it shows intense restriction on DWI and it appears hyper intense on the T2 weighted images. This is a typical case of cholesteatoma. So coming to what exactly is a cholesteatoma. So cholesteatomas are histologically equivalent to epidermoid cysts. This is a very important statement. Why? Because all the imaging features of a cholesteatoma is just like an epidermoid cyst. It is composed of desquamated keratinized stratified squamous epithelium which forms a mass. The most common type of cholesteatoma is pars flaccida cholesteatoma, which originates in Prussak space. So this is a very important space and has to be looked for in any imaging of the temporal bone, and it has to be reported because all the cholesteatomas usually originate from this particular space. So the anatomy of this space is very important. So how exactly this space is located within the temporal bone? So as you can see that this is the scutum, and this particular process is the lateral process of the malleus, and this is the lateral malleal ligament. So the boundaries of the Prussak space are this. So it is in the epitympanum and it is bounded by scutum, the lateral process of the malleus, the lateral malleal ligament, and the neck of the malleus. And this particular space is called the Prussak space. On imaging, as you can see in the epitympanum, this space is the Prussak space, and on coronal images, as you can see within the epitympanum, it is bounded by the scutum in the lateral side, and this is the Prussak space. So this is the pars flaccida cholesteatoma, which originates in the Prussak space, which is the most common type, and usually extends posteriorly, while pars tensa cholesteatoma originates in the posterior mesotympanum and tends to extend posteromedially, which is less common. So as I already described the appearance of cholesteatoma on my previous case on MRI, what exactly is the indication of MRI in a case of CSOM? So very important indication is post-operative cases. So post-operative cases, it's very difficult to differentiate cholesteatoma from granulation tissue and scar on a HRCT, because HRCT, everything will appear as soft tissue density. So definitely we have to get an MRI done to actually differentiate between these entities. Secondly, in case of subtle doubtful erosions of the tegment tympani, scutum, or such ossicles, we should definitely get an MR done to confirm the diagnosis. Another important indication for MR is facial nerve palsy. Can only be we can only see the erosion of the facial canal in a HRCT, but definite involvement of the facial nerve can only be confirmed on MR. So what tissue appears gives which signal on MRI is very important. Cholesteatoma appears hypointense on T1, hyperintense on T2, shows no enhancement, and it shows diffusion restriction, just like an epidermoid cyst. While granulation tissue will appear hypointense on T1, hyperintense on T2, just like a cholesteatoma, but it will not show any restriction on DWI, and it will show subtle post-contrast enhancement. While a scar tissue will appear hypointense or intermediate intensity on both T1 as well as on T2, and it will show no or delayed enhancement and no diffusion restriction. So the very important characteristic of a cholesteatoma that we have to remember on imaging is its diffusion restriction, because it is very highly specific for a cholesteatoma. Another important entity that can be seen within the middle ear, though it is more common in the petrous apex, is cholesterol granuloma. In cholesterol granuloma, the appearance is hyperintense on T1, hyperintense on T2 as well, and it will show no post-contrast enhancement, and it usually doesn't show any restriction on DWI. Secondly, cholesterol granuloma usually doesn't cause erosion of the surrounding bone in the middle ear. So what are the important points to be remembered while reporting CSOM case? So usually a bone erosion will point towards the diagnosis of cholesteatoma on HRCT itself. So why is MRI of the temporal bone required? So in cases of subtle suspected erosions, facial nerve palsy, post-operative cases particularly, to differentiate from residual cholesteatoma, the granulation tissue and scar tissue, which will all appear as soft tissue density within the middle ear, MRI is superior to CT and definitely will help in the diagnosis. So a good radiologist is a radiologist who knows his limitations. So it's not possible to diagnose residual cholesteatoma post-operative cases on an HRCT. So if a clinician asks you to do that, kindly ask them to get an MRI done. HRCT, the important points to be covered while reporting a case of cholesteatoma is erosion of the scutum, or even rather blunting of the scutum. Blunting of the scutum is something that is actually detected clinically. So if you write it in the report, if you see some blunting and you write it in the report, it definitely gives an idea to the clinician as to it's an early case of cholesteatoma and it is causing bone erosion. Erosion of the ossicles is a very common thing that I've seen. Rather than specifying which ossicle is eroded, erosion of the ossicles or disruption of the ossicles is given. So early involvement of the long process of incus is definitely seen. That two dot that you see while scrolling in the axial sections of the HRCT, one of the dot will be missing. That is the long process of incus. If you don't know, and if you see that there is some disruption of the ossicles and some erosion will be there, definitely look for long process of incus. Blindly you can say that the long process of incus will be involved. Malleus is quite resistant. It is only involved in the later case. I have not seen malleus involved and incus not involved in a case of cholesteatoma. So definitely long process of incus will be involved. Erosion of the tegment tympani. So this is a very important statement that I've seen commonly being reported. It is overdiagnosed. Erosion of tegment tympani, even in case of non-cholesteatoma, is given as erosion of tegment tympani. It turns out to be a simple case of CSOM and no. Why is this happening? Is because tegment tympani is a very thin bone, and often because of the chronic inflammation, there is some thinning or rarefaction, further thinning and rarefaction of that bone, and it is over reported as tegmentum. This is very important that you look for it with properly on all the sections. There is actually proper erosion or not. Secondly, when there is erosion, the clinician will ask you to report on herniation of the dura or the brain parenchyma within the ear cavity. So that is actually not seen on HRCT. HRCT itself is constructed in that particular window, where we do not see the brain parenchyma. So it cannot be reported in that way. We have to get an MRI done to definitely look for proper herniation of the dura or the brain parenchyma. So again, there is a limitation of HRCT in this particular case. If you give tegment tympani erosion and the clinician asks you for herniation of the dura or the brain parenchyma, get an MRI done. Then lateral semicircular canal dehiscence, which can lead to vertigo, has to be looked for in case of cholesteatoma. And the dehiscence of the facial nerve canal, always trace the facial nerve canal in whatever HRCT of the temporal bone. Again, you have to look at the anatomy for that. But all the segments of the facial nerve are to be looked for, and in the first thing that has to be done before looking for the dehiscence of the facial nerve canal is ask for a history, if there is facial nerve involvement clinically or not, because we'll be thinking that this cholesteatoma is actually involving this tympanic segment of the facial nerve. So we'll give as facial nerve palsy and the patient is completely normal. So the findings should coincide with the clinical history as well. Then integrity of the epitympanum, the mastoid antrum, and the oval and the round window are very important again. Then presence of cholesteatoma in the sinus tympani. So sinus tympani, again, the pyramidal eminence has facial recess and sinus tympani, the W shape. So it's very important that you comment on the sinus tympani in case of, in any case of cholesteatoma, definitely try to comment on sinus tympani, whether it is free of the cholesteatoma or whether some cholesteatoma residue is present within the sinus tympani. Why? Because it is actually blind while to that operating surgeon. He'll go through the facial recess and he will not be able to see in the sinus tympani because of the pyramidal eminence. So if you actually give that in the report that the sinus tympani is actually involved, then he will go into the sinus tympani to get that residual cholesteatoma out. Otherwise, he will just miss it. So this particular entity can only be seen by radiologists and hence has to be reported. So now coming to my next case, which is of a 9-year-old child who presented with right-sided sensory neural hearing loss and a history of meningitis 6 months back. And this is the HRCT done for this patient. And I'm scrolling from cranial to caudal direction. So mainly we look at the inner ear here. So here we can see that lateral semicircular canal, the vestibule, the apical and the middle turn of the cochlea, the modiolus and the otic capsule. This is very well seen here on the left side. On the right side, we can see that there is some ossification in the apical and the middle turn, and the lateral semicircular canal, the crux is not even seen because of this ossification. As you can see on the left side, you can compare it with on the left side, the right side, there is some ossification of the cochlea as well as the semicircular canals. So the diagnosis here is a labyrinthitis ossificans, ossification of the cochlea as well as the lateral semicircular canals will give this diagnosis because of the infection that was there 6 months back. That is why this child presented with sensory neural hearing loss. So look at the history very carefully. The middle ear and the ossicles and the mastoid hair cells are completely normal. Now coming to a companion case where a 75-year-old male presented with worsening sensory neural hearing loss on the left ear and has a history of flu 2 months ago. HRCT was completely normal in this case, and hence an MRI was actually done for this patient to look for inner ear pathology. So comparing, these are the cis sequence or fiesta sequence, heavily weighted T2 sequences where the inner ear structures will appear hyper intense because of the endolymph perineum. You can see this particular cochlea and the semicircular canals completely hyper intense on the right side. And there is T2 hyperintense mastoiditis as well that is seen bilaterally. On the left side, as we see, comparing it to the right side, we can see that there is no loss of normal T2 hyperintense signal within the cochlea, apical turn and the middle turn, as well as the semicircular canal, the lateral semicircular canal. Can see that there is loss of normal hyperintense T2 signal. This should not appear like this. Should be completely hyperintense because it is heavily T2 weighted image. So that suggests that there is some fibrosis or ossification. But as HRCT was completely clear, it is some fibrosis. So on T1 post-contrast images, the inner ear structure should not actually enhance on post-contrast images. But as we see on the left side, there is enhancement of the lateral semicircular canal and the vestibule. As you can see, that intense post-contrast enhancement that is seen, along with loss of T2 hyperintense signal, which is suggesting early fibrosis. It is indicative of acute or subacute labyrinthitis. On diffusion weighted imaging, again there was some restriction that was seen on the left inner ear structures, and on the right it was completely normal. So the diagnosis on MRI should be given as obliterative labyrinthitis unless and until you get an HRCT done and rule out labyrinthitis ossificans. Because obliterative labyrinthitis can be acute, subacute, fibrous and ossific. So it covers all the entities. So on MRI, definitely if only MRI is done, the term obliterative labyrinthitis is a better term to be used. Meningitis in childhood may cause labyrinthitis. Inflammation of the membranous labyrinth generally begins in the basal turn of the cochlea, and hence basal turn of the cochlea should always be looked first. It causes replacement of the fluid in the labyrinth with fibrous and later osseous material, which damages the nerve cells and the organ of motility. The CT may not reflect the fibrous component of the obliterative labyrinthitis, although it is a very good modality to pick up calcium, and hence labyrinthitis ossificans that our first case was, it is very easily picked up. So the first modality of investigation is usually HRCT. So if it is labyrinthitis ossificans, that will definitely be picked up on HRCT itself. But in case of fibrous or acute or subacute obliterative labyrinthitis, it is better to get an MRI done. And especially if there is a history of some meningitis or infection that is present in the patient. MRI is the gold standard for evaluation of fibrous obliteration of the membranous labyrinth, and delineation of the extent of the disease may lead to modification of the surgical approach in certain patients. So now coming to the next case, where a 55-year-old female presented with bilateral conductive deafness, and this is the HRCT. I'm concentrating mainly on the right ear now, and I want you to diagnose this particular entity. And mainly you have to concentrate on the external and the middle ear, because there is a history of conductive deafness. This is the tympanic membrane, this is the bony wall of the external ear, this is the middle ear cavity. So what exactly do we see here? Just look at the ossicles. There is some pathology here. Concentrate on that pathology. This is the head of the malleus, the short process of incus. This is the tympanic membrane again. As you're scrolling up, what we see is at the attachment of the stapes, just anterior to the attachment of the stapes, there is a hypodense area involving the otic capsule, that is indicating demineralization of the otic capsule, just anterior to the oval window or the attachment of the footplate of the stapes, a typical site of involvement of otosclerosis or otospongiosis. So this is a fenestral type of otosclerosis. Coming to a companion case where a 25-year-old female presented with progressive mixed type of hearing loss bilaterally, Just take a look at the HRCT of the temporal bone bilaterally. We look on the right ear, focus on the right ear particularly. The coming to that otic capsule again, there is demineralization or reduced density that is seen not only just anterior to the oval window but also in the round window niche, and it is completely involving uh, the part of the otic capsule that is adjacent to the attachment of the foot plate of the stapes. Now coming, the mastoid air cells are completely normal. The lateral semicircular canal, the vestibule, the superior semicircular canal, everything is normal here. So this is the head of the malleus, the body of the incus and the short process of incus. Now we can see this complete pathological area that is adjacent to the basal turn of the cochlea. This is the basal turn of the cochlea. Adjacent to the basal turn of the cochlea, the oval window, just anterior to the oval window. So this is fenestral as well as retrofenestral involvement. You can see that demineralization of the otic capsule that is seen. This is the apical turn, the middle turn of the cochlea. Everything else is normal, but you can see this particular pathological area that is demineralized. So the diagnosis here is retrofenestral as well as fenestral otosclerosis. So what exactly is otosclerosis or otospongiosis? It's a primary osteodystrophy of the otic capsule or the bony labyrinth of the inner ear, and is one of the leading causes of deafness in adults. It has two major subtypes, that is fenestral or stapedial and retrofenestral or cochlear. While fenestral or stapedial is the more common subtype, and it involves the oval window and the stapes foot plate, and hearing loss is often conductive because of the stapes thickening and fixation, while retrofenestral type is cochlear involvement with demineralization of the cochlear capsule, and hearing loss is often sensory neural, but the mechanism by which it occurs is uncertain. So what we have to remember is in otosclerosis, we can get both conductive as well as sensory neural hearing loss depending on its type. Usually retrofenestral accompanies fenestral otosclerosis. So on imaging particularly, what do we find? On fenestral type, which is the most common type, the site of involvement is just anterior to the oval window involving a small cleft called fissula ante fenestram. So this was a typical site of involvement in our first case, that is fissula ante fenestram, which has to be looked for in any case of conductive deafness. And it is the earliest site of involvement. So only that small hypodense area in that fissula ante fenestram will point towards the diagnosis of otosclerosis in a patient having conductive deafness. Particularly a female in middle age. Bony overgrowth can cause fixation of the stapes. Retrofenestral type is second common, where there is involvement of the round window niche, which was present, usually accompanies fenestral disease. The bone surrounding the cochlea is the site of involvement, which may lead to focal or circumferential uh, demineralization, giving rise to fourth turn or double ring sign. So this is what we have to remember. It was called the second case, fourth ring or double ring sign, that hypodense area adjacent to the basal turn of the cochlea. Then the findings depend on the phase, that is otospongiotic phase or otosclerotic phase. Whether the disease in the otospongiotic phase, if the disease in the otospongiotic phase, we get demineralization and formation of spongy bone, what we saw in our case. And most common presentation is otospongiotic phase only, where we see demineralization and hypodense or lucent area in the otic capsule. While otosclerotic phase, which is less common, leads to increase in attenuation, and in severe cases, the oval window or less commonly the round window is completely dense bony plate, and there is complete fixation of the stapes. But this is the more common phase and presentation that we come across. Now coming to the exact location of fissula ante fenestram, that is the origin of the fenestral otosclerosis. So this is the fissula ante fenestram. This is a normal fissula ante fenestram that is just anterior to the oval window. These are the limbs of the stapes and the foot plate of the stapes. Attachment of the foot plate of the stapes at the oval window, and just anterior to it is the fissula ante fenestram. This is the middle and apical turn of the cochlea. This is the vestibule. So this is the stapes, and the foot plate of stapes attaches here, and just anterior to it is the fissula ante fenestram. In an adult, if there is a demineralization there or hypodensity there, definitely a possibility of fenestral otosclerosis has to be given in the report. While in case of a pediatric age, in a pediatric age group, uh, there is a possibility of cochlear cleft also. Cochlear cleft also appears a bit hypodense, and it will also be present here in a pediatric age group. So the diagnosis is a bit difficult there. Then coming to the next case, where we have a 2-year-old male who presented with deafness since birth. And this is the HRCT picture of this particular patient. So what is the diagnosis here? So as I'm scrolling, what do we see here on these axial sections is that there is complete absence of the petrous part of the temporal bone or the otic capsule, and there is complete absence of the inner ear structures of the bony labyrinth. As you can see, there is no inner ear structure or bony labyrinth that is seen in this child. So what is the diagnosis here? It's a spot diagnosis. It's case of Michael dysplasia. So this is a list of all the inner ear malformations that we come across in our clinical practice. And it's very important, particularly if you are practicing in a place where cochlear implants are being done frequently, or even for your exams, where so many spots are being asked from these particular entities. So what I just showed you was actually Michael's deformity or Michael aplasia. This is the week of origin of that particular malformation. And there is complete absence of the inner ear structures in this particular entity. Then according to the week of gestation in which this particular malformation manifests, it is being characterized as cochlear aplasia, common cavity, type 1 incomplete partition of the cochlea, cochlear hypoplasia, type 2 incomplete partition of the cochlea, and malformations of the superior semicircular canal. So there are certain ways in which we can actually diagnose each of them and in imaging, and some of them I'll be discussing in my future slides. Now coming to a inner ear malformation called the common cavity. So what exactly do we mean by common cavity? So common cavity means there is a confluence of the cochlea, vestibule, horizontal semicircular canal in a cystic cavity of variable size and no internal architecture. And the internal acoustic meatus opens just in the middle of the cystic cavity. So there is no differentiation between the cochlea and the vestibule. There is just a common cavity. And the width of the cavity is typically greater than its height, is what we have to remember for the diagnosis. The posterior and the superior semicircular canals are absent, normal, or malformed, and the vestibulocochlear nerve is small or has absent components. The facial canal will have anomalous course, and the ossicles are normal, or anomalous stapes might be present. The vestibular aqueduct is not dilated and may be absent. This is very important. The vestibular aqueduct, which is actually present here, is not dilated here. So there is no differentiation between cochlea and the vestibule. There is a common cavity, and the width of the cavity is greater than its height, and the vestibular aqueduct is not dilated, is what we have to remember here. So again, this is a diagrammatic representation of a common cavity. As we can see, there is a common cavity. There is no differentiation between cochlea and the vestibule. And this is the internal acoustic meatus, a dilated, enlarged internal acoustic canal. So now how do we differentiate between a common cavity and cochlear aplasia with dilated vestibule? So cochlear aplasia is commonly associated with dilated vestibule. So how do we differentiate between a common cavity and CADV? So common cavity, as I already explained, that the internal acoustic meatus actually opens in the mid part of the common cavity. While in case of a cochlear aplasia, there is nothing in front or anterior to the internal acoustic meatus. There is the cystic dilatate structure is only present posterior to the internal acoustic meatus. As we can see here, that this internal acoustic canal is actually opening here in the midway. There is anteriorly and posteriorly dilated structures which are communicating. This is a common cavity. While here there is internal acoustic meatus, and anterior to the internal acoustic canal there is nothing. There is no dilated cavity. Only posterior to it is the dilated cavity that is present. So this is actually a cochlear aplasia with dilated vestibule. So coming to the incomplete partition of the cochlea, so this is a gross diagram that we have to remember or keep in mind, especially for spotters. That IP1, IP2, IP3. IP3 I am not discussing in this particular video. I'll be discussing IP1 and IP2 mainly. So this is the IP1 and this is the IP2. So IP1 has absent modulus as well as interscalar septa, while IP2 has deficient modulus, but modulus is actually present. So as we can see in IP2, the apical and the middle turn are actually fused with each other, while the basal turn can very well be appreciated. While in case of IP1, there is no modulus, and as such, the turns are not very well differentiated. But it is different from the common cavity. Why? Because we can see that there are two different cavities that are present. One anterior to the internal acoustic canal, which is actually the cochlea, and one is posterior, that is the vestibule. The third type actually has a corkscrew appearance because of the presence of the interscalar septa. So coming to the IP1, what exactly is IP1? So IP1, the cochlea is clearly differentiated from the vestibule, and hence it's not a common cavity. And the external dimensions of the cochlea are nearly normal. So this is very important statement. This is how we differentiate it from cochlear hypoplasia. So the dimension, the size of the cochlea is normal, though it's not very well differentiated into the turns because of absence of modulus of the interscalar septum. But there is complete partition from the vestibule, one, because it is located anterior to the internal acoustic canal. Second, there is normal size of the cochlear structure that is seen. There is cystic cochleovestibular malformation giving a figure of 8 appearance. This is typical figure of 8 appearance that you see is characteristic of IP1. And there is no large vestibular aqueduct. There is usually not associated with a large vestibular aqueduct. So there is no gusher in this particular case. But there are exceptions. But what we have to typically remember is this figure of 8 appearance, no large vestibular aqueduct, absence of modulus, and cystic cochleovestibular malformation. It's typically IP1. Now coming to IP2, which is commonly confused with Mondini anomaly. Mondini anomaly is different. Why? I'll be coming to that. What exactly happens in IP2? IP2, there is 1.5 turns of the cochlea with fusion of the apical and the middle turn to form a cystic apex. So this is the cystic apex, and the basal turn is completely normal. So there is a modulus present in IP2, unlike IP1, though it is deficient. The interscalar septum is anyways absent. Now, when do we call IP2 as Mondini anomaly? So, Mondini anomaly, it is called when there is a large vestibular aqueduct and an enlarged vestibule that is associated with IP2, which has high risk of gusher. So, in that case, we call it as IP2. Then the point to be remembered in all these congenital anomalies of the inner ear are, as the gestational age progresses, it is from more complete to an incomplete anomaly, from bony labyrinth anomaly to a membranous labyrinth anomaly, from uncommon anomalies to a more common anomaly. So now coming to my next case, where this patient presented with progressive sensorineural hearing loss on the left side. HRCT was done, it was normal. Even an MRI was done with cis sequence, which turned out to be normal in this particular patient. But the sensorineural hearing loss was progressively increasing. So finally, a T1 post-contrast MRI was performed with thin sections, and the diagnosis was actually made or confirmed in this particular case. Now, it's a very subtle finding you have to look for really well. Now you have to trace the cochlear nerve on the left side. So what we can see here, there is subtle, very subtle, small enhancing area that is seen in the intracochlear portion of the nerve. This particular area, as you compare to the right side, this area, as you can see. On the right side, it's not there. On the left side, the small enhancing area that you can see here on the post contrast images, the small dot. And this is a screenshot of this particular area, the small dot that you see in the cochlea, particularly in the basal turn. In the post contrast images is typically the diagnosis that is made is of intracochlear schwannoma, which is typically rare. So what exactly is intracochlear schwannoma? So intracochlear schwannoma is a subtype of intralabyrinthine schwannoma. And intralabyrinthine schwannoma is a schwannoma that arises within the membranous labyrinth, that is within the cochlea, vestibule, or semicircular canals, which is different from vestibular schwannomas that typically arise from the inferior vestibular nerve, or vestibular schwannomas with intracanalicular, intracochlear extensions. They are completely different entities as compared to intralabyrinthine schwannomas. So to diagnose intralabyrinthine schwannomas or intracochlear schwannomas, typically thin T1 post-contrast sections are required. So a patient who's presenting with progressive sensory neural hearing loss and there is no diagnosis on CIS images, and there is suspected schwannoma, definitely we should get a T1 thin post-contrast sections to look for intralabyrinthine schwannomas. So Schwann cells of the cochlear axons in the cochlear nerve typically are present in the modulus, and the intracochlear schwannoma could arise in the modulus and then grow from the modulus and occupy the cochlear basal turn, then erode the cribriform plate of the internal acoustic canal and spread into the vestibule. This is a very important entity that has to be kept in mind for sensory neural hearing loss and a normal CP angle. Now coming to another interesting case where a 22-year-old female presented with right-sided hearing loss, tinnitus and vertigo. So this is a spot diagnosis on HRCT itself. What is the diagnosis and what else do we evaluate for in this particular case is what is important. So this we can see a permeative destruction of the temporal bone that is seen here just at the site of the vestibular canal. On this HRCT image is a permeative destruction of the petrous part of the temporal bone is seen at the site of the vestibular aqueduct. So vestibular aqueduct is a typical site within which the endolymphatic sac is present, and on MR the diagnosis is actually confirmed as there is a multiloculated cystic lesion that is seen at the site of the endolymphatic sac on the right side. On the left side it is completely normal. On the right side this particular tumor is present. So it's a endolymphatic sac tumor. So endolymphatic sac tumor are rare entities. They are locally invasive tumors, and early detection of these tumors is critical because early surgical intervention may prevent further hearing loss. Though endolymphatic sac tumors do not metastasize, they are only locally aggressive. They often are associated with VHL disease and are detected in 11 to 16% of the patients with VHL. And generally, the endolymphatic sac tumors may arise within the vestibular aqueduct, involving the endolymphatic sac or duct. The lesion is typically centered in the posterior retrolabyrinthine petrous part of the temporal bone. So coming to my next case where we have a 50-year-old male who presents with vertigo and nystagmus induced by loud noises, typically called Tullio phenomenon. So we look at the inner ear for this because this is the function of inner ear, the balance. And a typical diagnosis in Tullio phenomenon is, we all know that entity, that is superior semicircular canal dehiscence. Now we have to look for how it looks in a HRCT of the temporal. You can see this is the superior semicircular canal. Now when we see this superior semicircular canal, you can see that there is no bony wall superior to this canal that is seen. The bony wall is absent superior to this superior semicircular canal, which is indicating dehiscence of the superior semicircular canal, and it is causing this particular symptom. The superior semicircular canal dehiscence is inner ear abnormality where there is clinical disequilibrium phenomenon that is associated with absence of bony covering of the superior semicircular canal. The slice petrous temporal bone CT demonstrates a defect in the arcuate eminence or the bony covering of the superior semicircular canal, which is best seen in the coronal images only. So that is why I showed you the coronal images of that particular patient, the HRCT. And using thin sections will definitely improve the detection rates. So finally, I would wrap up this session with the mention of my book, that is Radio Nerds Physics Questions and Key Concepts. And these are some of the snippets from my book, which typically I have carefully curated to include all the important questions and key concepts that are required for the radio physics exam, particularly the FRCR, but also for the MD and DNB students. And you can WhatsApp on this particular number for further queries. The sample paper that is present in my book is available for free. You just have to WhatsApp on this number, sample paper, and I'll be sending you the sample paper.